For joining us today. Today, we are here to talk about gestational diabetes or diabetes during pregnancy and postpartum or post-delivery care. Most of you would know that we have talked about gestational diabetes before as well, and we will touch on that a little bit. Today, we are very privileged to have with us a panel of Dr. Tarakeswari, who's MD, OBGYN, senior consultant, and head medicine unit at Obstetric medicine unit at Fernandez Hospitals. We've got Dr. Usha Sriram, who is a physician, endocrinology, and diabetes specialist, women's health promoter, and founder of DIWAS. And she's been passionate and working with us as PatientsEngage on women's health and diabetes. We've got Dr. Shital Patel, who's a lactation counselor as well as a medical advisor at PatientsEngage, and I'm Aparna Mittal. I am founder of PatientsEngage, and I'll be the moderator of the session. As I said, about a month back, we talked about diabetes during pregnancy, what you must know, how to manage it during the pregnancy, and you can find the recordings of this on our YouTube channel. So do check it out. It is very useful information for women who are going through or even planning to get pregnant, so that you plan for a healthy pregnancy. Quick reminder, PatientsEngage is an online platform for patients dealing with chronic disease and their caregivers to share personal experiences, information, and learn from each other. And we do believe that the better informed you are, the better empowered you will feel, and you will make better choices. And we do believe that, again, it's not just about managing a condition, but it's also about preventing conditions, especially these non-communicable diseases and chronic conditions. As always, you can reach us on our social media platforms. We are on Facebook, Instagram, Twitter, YouTube, LinkedIn, or you can reach us on our website at www.patientsengage.com or write to us at editor@patientsengage.com. And this information here does not replace a medical consultation. So please do remember that if you have specific medical issues, please do reach out to your doctor or any of the doctors on the panel here separately. And I'm sure they will be happy to figure out how you can be assisted. So thank you once again to our panel for joining us today. Dr. Usha, can you quickly remind the audience as to what is gestational diabetes, so that people are clear on that?
Thank you, Aparna. Thank you for this invitation to be part of the program again. And I'm delighted to be on the panel with Dr. Tarakeswari and Dr. Shital Patel. So gestational diabetes is the high blood sugars that are first found when a woman is pregnant. This obviously does not include anyone who has been given a diagnosis of diabetes before the pregnancy, whether it's type 1 or type 2. We call that pre-gestational diabetes. And so the gestational diabetes is when we diagnose high blood sugars during pregnancy. And I say high blood sugars are not diabetes is because, diabetes itself has some different blood sugar cutoffs, and anything that is higher than what it should be in pregnancy, we call that as gestational diabetes. It is the most common medical condition during a pregnancy. In India, it's around somewhere between 10 and 15% of all pregnancies. Globally, somewhere anywhere between 5 and 10%, approximately 20 million women have gestational diabetes in the world every year. And India alone is somewhere around 3 to 5 million women every year. And it's something that is very significant because it has an impact on the growing baby and also on the mother, both during pregnancy and later in their life, which is why it's very important that we talk about it. And for the baby, we usually it is something the babies tend to, the mother's sugar goes to them, and the baby gets a little, big or fat, and we call that large for gestational age or macrosomia. And so when the baby is big, mother ends up having cesarean section, long hospital stays, birth canal injuries. And the baby also, when it comes out, can have some birth injuries as well. But what we are really concerned about is that this baby in the future, and not in the distant future, even in their childhood and teens, can develop diabetes or obesity and neurodevelopmental issues, which is a big concern now. And the mom can develop, very, very importantly, after the pregnancy, type 2 diabetes or heart disease or what we call non-alcoholic fatty liver. These are all things that we are concerned about, which is why we are having this discussion today.
Thank you. Thank you, Dr. Usha. So Dr. Tara, if you can tell us, as I said previously, we've talked about how to manage a pregnancy if you are diagnosed with gestational diabetes, but can you tell us what happens after the delivery and, typically what is normal blood sugar levels post-delivery and how is it different for women who've been diagnosed with gestational diabetes?
After the delivery, the gestational diabetic mothers, their blood sugars come back to normal. So majority of them, they don't require medication, particularly these gestational diabetic mothers, unlike the pre-gestational diabetic mothers. Right. So we put them on the normal diet. We don't tell them to restrict because they're breastfeeding the babies. And we check the blood sugars, but we educate the mother that she requires another test between 4 to 12 weeks post-delivery to look at their oral glucose tolerance test. If it is normal, but we need to tell them to do it at least once in a year, because there is a 10-fold increase of developing diabetes, as Dr. Usha mentioned, in the later life, and it increases in linear proportion at the age of the mother. So by 10 years after the GDM pregnant mother, 20% of them can become diabetic. So in the gestational diabetes, usually the blood sugars, they come back to normal after delivery.
Right. Okay. Okay. And you said, but if somebody had undiagnosed diabetes, which only got diagnosed during pregnancy, or they already had diabetes before pregnancy, then how does the blood sugar still come back to kind of normal, or it goes back to that, what was the state before the pregnancy?
They will require medication. They don't come back to normal post-delivery, and they will definitely require medication. But 30 to 32% of the insulin requirements prior to pregnancy, what they have, they need. So we need to cut down and titrate the insulin dosage or the medication for them. They are not completely normal. We need to monitor the sugars to at least 24 hours after their diet, and they require a modification of their diet too.
Right. And Dr. Usha, most of the times the diabetes blood sugar levels come down to normal. Do they always come down, or are there some cases where it will not come down even if it was just pure gestational diabetes? And does it then need to be treated?
Yeah, some women do not come down. In fact, the pregnancy is actually like a stress test. It's a diabetogenic event. So somebody who might have had pre-diabetes before they got pregnant, or a metabolic syndrome, not a frank diabetes, and then during pregnancy got unmasked, and then many of them will remain or maybe undiagnosed diabetes, and they walked into a pregnancy with that, and therefore post-pregnancy it will remain as diabetes. And as Dr. Tara said, during pregnancy, their insulin requirements would have gone up tremendously, because that's what happens during pregnancy. All the pregnancy hormones are anti-insulin hormones, so they make the sugars go up. So we would have bumped up their insulin or put them on medications through the pregnancy. And as soon as the baby comes out and the pregnancy hormones all come down, right, and they are breastfeeding, so definitely their medication requirement will be down a lot. Some may not require medication at all, but they need to be on a healthy diet. See, that's very important, because this idea of you can eat anything you want should not be, is not something that they should take with them. They should eat healthy. And very importantly, nearly 20% of women in the first year after delivery itself develop some form of what we call dysglycemia now, meaning it's not normal sugar. It may be pre-diabetes, it may be diabetes, just impaired fasting glucose or an impaired glucose tolerance test. One of those, a permutation combination of one of those, 20% of that's what we found in the WING study from Chennai, that 20%. And so doesn't come back to normal in everyone. And so important that 4 to 12-week tests that Dr. Tara talked about.
Right, right. And Dr. Tara, you talked about how it increases and therefore it needs to be monitored carefully. I know we touched on this last time as well, but I think it's important to touch upon this. So if there are future pregnancies, what are you advising these women to also be careful about if they're planning one more pregnancy after having had gestational diabetes in their earlier pregnancy?
So we also participated in few studies posting cards to these mothers. How are your blood sugars after 6 months, 1 year, and if there are higher lifestyle interventions following up. But since the follow-up methodology, and because going to the grassroots level and approaching these mothers at the home is not so well planned, we are losing that type of a connectivity with them. But it is important that they understand when they get discharged from the hospital, in some way we communicate with them regularly. How are you doing? How much is your weight gain? Inter-pregnancy weight gain is very important. And how are your blood sugars? What you have been doing? Because as Dr. Usha told us, the dysglycemia after 1 year is 20%. So despite being in a tertiary referral care hospital here, and the women whom we have birthed 5 years ago, they come back with pregnancy with a high sugar in the first trimester. You feel defeated. But to understand, I think we have to have a good support social service systems to take care of these mothers, I feel, during the interpregnancy period. So definitely they have to keep a watch on their weight gain and monitor their blood sugars.
So just on that, right, and I know I'm kind of digressing a little bit, but our mechanisms for community health are supposed to support, I guess the focus is more on the baby till the baby is 5, but is that also a window to be able to support the mother?
May
For
I answer
either
that?
of you? Yes, yes, either of you.
I think ideally that would be great. Government programs are all only up to 42 days. So
for the mother.
For the mother. After 42 days, she's on her own. So we definitely need a bridge, a handing over of sorts of these women to the NCD clinics. But that process is not there. I'm working on that. The second thing is, of course, a move to link immunization, the baby, with maternal, reinforcement of testing and follow-up and lifestyle and all that. Then, but we also know that pediatrician clinics are all already bursting at the seams, and and do they have the bandwidth, meaning the nurses and other things needed to do this? That again is something the government needs to step in and work on, and also as individuals, we are going to launch a teaching education program called Sweet Pea, which is exactly this. So that we need. And then in Sri Lanka, they have a program called, which is public health midwives.
Right.
Programs. So who will be this bridge between the patient and the doctor. So those kind of things, empowering frontline health workers to be the coaches. We need all of that. It takes a village, as they say, and we don't have the village yet.
Right. Yeah, I'm just hoping that the midwifery program can be extended. That Fernandez Hospitals is actively pushing. So, Dr. Tara, I know we talked of that women who've had gestational diabetes, their risk for having a baby who will develop diabetes at some point increases. Can you talk us through what the risk factors are and what you typically tell a mother
When
or the
we,
family?
yeah, one is a known diabetic coming into the clinic, or we pick up the gestational diabetes and talking to her, because she herself, she has to be watchful about her BMI and weight gain during the pregnancy. The risk of development of hypertension and preterm birth is more,
Right.
and the baby being macrosomic, and then prolonged labor, difficult birth, and the baby later life developing obesity. So we'll talk to her about the maternal factors and the fetal factors and the outcome at the time of birth, and then the follow-up of the baby. So first time it is very difficult to talk everything. Suppose a lean mother comes and we started doing screening HbA1c once we standardize the technique. And if high risk, we screen at 16 weeks and then at 24 to 28 weeks. And 24 to 28 weeks, first time when we say that, your sugars are a little higher. So we bring in slowly the medical nutrition therapy. And we tell them, like, if you're good and you eat healthy food, 80% of you may not require any medication. Let's work slowly. Your sugars are a little higher than normal. But we have to be communicating with them every 2 weeks over the phone or a teleconsult instead of bringing them to the hospital.
Right.
At the same time, monitoring the fetal growth is important. So that's how we bring them to understand the problem. And first thing they say is, no, there is no diabetes in the family. My mother never had, none, my sister never had, and your sister, your test may be wrong, and they'd redo it somewhere else. So we tell them slowly, no, these changes can happen during pregnancy. So let's wait and watch. I'm not labeling you, but because these days they become very they misunderstand the information. The Google gives them a lot of some information, colleagues give them some information. So explain to them about the risk, because they stand higher risk of hypertension and premature births. And similarly, they have excess of urinary infections. Some mothers develop urinary tract infections and repeated infections, not amenable sometimes to antibiotics. So, and also their basic BMI, because now we look at 30% has become normal BMI. It was not like this 20 years ago. Dr. Usha may be knowing. So 30%, 30 BMI is normal. Like 30% of the mothers coming to clinic, they start with a BMI of 30.
Wow. Yeah. Okay. So I know that we've talked of the fact that the diabetes risk is higher for the mother, but Dr. Usha, can you also tell us a little bit about the medium and long-term consequences for the mother?
So, immediately after the, baby is born, like I said, all this operative delivery and, birth canal injuries and all that apart, when they take the baby and go home, there's also a link between gestational diabetes and postpartum depression. So that is something that we absolutely must be cognizant of, and not there's a tendency when the mother says, I'm feeling moody or VP, or I feel this way. There's a new mother, that's how you would feel, because you're not sleeping because of this. Instead of that, I'm saying we need to be aware that there could be some truly possible postpartum depression. So any woman who is experiencing any of these things should reach out to their family and their doctor. Very important. And then, going forward, the next pregnancy to me is like probably the next important thing that is going to happen in the next couple of years or 3-4 years. So postpartum of the index pregnancy, when I say index, the time when you got diagnosed with GDM, right? Okay. That is the index pregnancy.
Right.
The postpartum of that is the preconception care of the next pregnancy. So Dr. Shital is going to talk to us about breastfeeding. So important. Next, all of us think that when we breastfeed, we can't get pregnant. Usually not, but surprise, surprise, can happen. So, so contraception discussion, very, very important, and not to become sexually active unless contraception is in place. And the good news is all contraceptives are good for women with diabetes. So, and of course, based upon what your obstetrician recommends to you. So that is very important. And then this test at 4 to 12 weeks. And why is that important? Because they only then we'll know, are you normal? Are you having diabetes, or are you having pre-diabetes? And based upon what is there, it may just be a good healthy diet and physical activity, or it may be that plus a tablet, or insulin, depending on what type of diabetes, how much, and all of those things. So that's a medical decision. So the test is very, very important. Going forward, as Dr. Tara has already mentioned, this type 2 diabetes developing in women is our biggest concern. Within 5 to 10 years, and when we say 5 to 10 years, already these people are only in their 20s, 30s, maybe early 40s. Imagine when you say 5 to 10 years, they're still only in their 30s and 40s. They develop diabetes, a big chunk. So when you have that, I am an endocrinologist. I see all the consequences of diabetes in women. They definitely have more complications: heart disease, stroke, fractures, kidney problem, eye problem, depression, all of this. So I want women, the best way to treat diabetes, Aparna, is not to get it.
Yeah.
Right? So if you should not get diabetes, you should make sure that post the gestational diabetes pregnancy, you take this upon yourself to eat healthy, be physically active, sleep well, lower stress, get periodic testing, just get on a healthy trajectory for life. I tell all my women, think of this as don't lose sleep over it. Just think of it as a wake-up call.
Right.
Pardon the pun. You think of it as a wake-up call, and you take this very seriously. Then the other complications that I worry about for gestational diabetes is heart disease. We always think that women don't get heart disease, or if they get it only when they're 70, 75. No, they've shown that women with gestational diabetes can get it even earlier, even in their 40s, 50s, and 60s. So we have to not only control sugar, know what the blood pressure is, know what the cholesterol is, keep the weight down, all of that. Then this new information we are getting about the non-alcoholic fatty liver. So that seems to be also higher in women who have had gestational diabetes. So for all these reasons, there's breast cancer, there's some evidence that it is increased, some evidence saying it's not. So the jury is out on that one. But you know that anyone who's got diabetes is at risk for cancers.
Right.
Especially breast cancer. So better not to get it. So this is why I'm very concerned about it.
Thank you, Dr. Usha. Dr. Tara, I mean, we touched a little bit on nutritional and exercise being important. What are the typical guidelines that you give to women after they've finished their delivery? So postpartum nutrition and exercise guidelines.
One of the things we should tell them is depending upon their BMI, and not to gain excessive weight. Because she's breastfeeding, as Dr. Shital mentioned, different types of food is given as a cultural part of your at home. They give the foods, and excessive weight gain, again, it's a precursor for the diabetes. So to have a me time, catch some time for yourself, at least walk, go for a walk. start doing it depending upon how you are coping up with the feeding and systems at home. So some part of exercise, it can be like swimming, it can be just a running or a brisk walking. At least start with the simple thing which is possible for you rather than not doing anything. And the diet part of it, she has to be careful on her complex carbohydrate. And not that she shouldn't eat fruits, she can eat fruit, but juices better not to avoid. And also the fat, cut down on the fat. So lean meat is okay, egg is okay. So we talk to her and write about the plan, at the same time not compromising on the breastfeeding part of it.
Right, right. Thank you. So Dr. Shital, if you can very quickly tell our audience what you mean by the term lactation and how does gestational diabetes affect lactation?
Okay, so lactation is basically the production of milk that every new mother goes through in order to be able to breastfeed their newborn baby. So it is a very natural process, and we all who deliver will go through the period of lactation. What happens with women who have gestational diabetes is diabetes by nature reduces the sensitivity to insulin. So it is known to affect the production of milk itself. So this causes a delay in the onset of lactation. So this will be something that a lot of new mothers with gestational lactation, with gestational diabetes will see. So we recommend that you breastfeed within the first 2 hours immediately post-delivery. And the delay is especially more prominent in women who are on insulin, if they're obese, or if they've had a complicated delivery due to high blood sugar levels. But the important thing is that this should not deter them from breastfeeding, because research has found that actually breastfeeding will increase insulin sensitivity and also help with the glucose metabolism for the mother. So over time, even if they are able to feed for 2 to 3 months, I've seen that it improves postpartum glycemic control and even lowers their HbA1c levels.
Thank you. So there is often this fear, right, that my blood sugar or glucose will pass on to the baby via breast milk. Is that true, not true? What happens in that process?
So yes, glucose does pass on from the mother's milk to the baby. So that is why, controlling the blood sugar levels of the mother, like Dr. Tara was saying, is then very essential at any point during the postpartum period.
Okay. And are there any restrictions? Are there any cases where breastfeeding is not, or are there restrictions in terms of, okay, you should not do it postprandial or whatever, time-based restrictions or any other reading-based restrictions?
So there's actually no reason why, you cannot breastfeed your baby if you have gestational diabetes. One thing to note is that during a breastfeeding session, the blood glucose levels can actually drop. So in some cases, they can drop till between 50 to 90. So it is important that women are aware of that, and they can take those special precautions, talk to their lactation expert or their doctor to make sure that they avoid those periods of hypoglycemia, during those periods. So there are a lot of tips that, we give moms, to make sure that they are either snacking, while they're breastfeeding. So I recommend that they always have healthy snacks handy where they are going to be sitting to breastfeed. So it's easier for them to munch on something. They always have a bottle of water so they can sip on lots of water. They can also, monitor before and after a breastfeeding session so they can better keep control. And if they do have these sudden dips, and if they're really low, then they can keep a log. So for instance, I see a lot of nighttime dips. That's when, the mother will wake up, feed the baby, and go back to sleep. So there's not a lot of, eating or sipping on water, or even, checking your glucose levels right in the night. So those nighttime dips can be avoided as well. So moms need to be made aware of, a few of these things.
Right. Thank you. Dr.
Aparna,
Usha?
can I just
Yeah.
add one more thing? Sorry,
Go ahead.
just wanted to add that one more thing that I tell people who are on medications, that to first breastfeed and then take the medicine, not from a glucose dipping. That I think that's also a very good point. But also because all medicines go through the breast milk to the baby, even if it's a tiny amount. So first feed the baby, then take your tablet. And this way, it doesn't go to the baby. And by the time the next feed happens, the level of the medication has come down in the blood.
Right. And are there any specific restrictions on any types of medication that are allowed, not allowed during breastfeeding?
So the only medicines that we are allowing are, of course, insulin is allowed. Metformin is allowed, even though it does cross the both the placenta and the breast milk a tiny little bit. And the sulfonylureas, especially the short-acting ones like glipizide and things like that, can be given, because then the levels will quickly come down, not the long-acting ones. And we don't use all the newer agents like DPP4, SGLT2, and all that during breastfeeding, because we do not know its effect on the baby. Though there are studies actually started now going on to see if certain agents can prevent diabetes in the mother. Yeah.
Right. Dr. Tara, we've got a question on, a question whether women with gestational diabetes will only have a cesarean delivery, or can they have a normal delivery as well? Sorry, you're on mute, Dr. Tara.
Sorry, they can have a normal delivery, not that diabetes and we need to do a section. It depends upon the comorbid condition. Suppose she has the morbid obesity and the fetal macrosomia, we say the baby is more than 4 kilos, even though American College and Royal College takes 4.5 as a cutoff. Unless there are comorbid conditions, otherwise a pure gestational diabetes, there is no contraindication for a vaginal birth.
Right. And and this is to any of y'all, will breastfeeding transfer the diabetes? I know we talked about the blood sugar, but will the baby get diabetic because they are being breastfed by a mother who's had gestational diabetes, or is herself diabetic?
No.
Okay.
Breastfeeding is so good in so many ways.
Right.
And it lowers the risk of future type 2 diabetes by some incredible number, like 60-70%. So we think, if we can really talk about this with the mothers well before their even delivery, constantly, bring this in so that they do this 6-month exclusive and 12 to 18 months complementary. The longer they breastfeed, the better it is both for them. And of course, babies who are breastfed typically are not obese. And so good for the baby as well. So really, we need to push breastfeeding.
Okay, thank you. And is sometimes babies are larger after a gestational diabetes delivery. So is that because the diabetes has transferred through, or there is this whole concern and confusion as to why that leads to a bigger? How do you explain that in layman terms?
One of the things, the large for size gestation babies, it can be a component of uncontrolled blood sugars. At the same time, there is a genetic component also. So the effect of the diabetes and uncontrolled sugars is one way. When we look at the fetal growth assessment by the ultrasound, we tend to know this baby is bigger, or there is a lot of fluid called polyhydramnios that can be secondary to the blood sugars. So after birth, if the babies are bigger, these are the babies we need to monitor them for they can have low blood sugars, they can have the calcium levels, the magnesium levels. These are the things that have to be monitored apart from the feeding issues. So diabetes contributes to a larger baby until it is uncontrolled. Well-controlled diabetes may not.
Right. So, any other myths or anything, Dr. Shital, that you want to touch on as far as lactation is concerned? I think we've covered most of them, but if there's anything that comes to your mind,
I think
any of you all have.
Right. I think some of them are concerned that if insulin is safe to use during breastfeeding, and that is a common myth. So I do tell patients that we know that insulin molecules actually considered too big to pass through the mother's blood into the milk. So, and I think Dr. Usha also mentioned that it's easier if, we take if the mom takes medications after the breastfeeding sessions, because metformin is known to pass through the milk. And some of the other myths, I think something we've already debunked is if gestational diabetes is permanent and if it's irreversible. I think we've already debunked that. And if eating sugar can lead to gestational diabetes.
Yeah, that's I think a diabetes question. Does eating sugar cause diabetes? So I think coming to the topic that Dr. Usha raised as well on postpartum depression, I think Dr. Tara, if you can talk about how you, how do you, because one of the things we've found is that even when a woman is going through postpartum depression, she is often unable to diagnose it as depression, and her family members are kind of unaware or they don't know that it's depression as well, even those who probably would have taken action. So how do you recommend, or how do you figure out, what is your evaluation process that you would recommend, and how do you then, kind of advise them in terms of management?
Thank you, Aparna. That is a very good question, because perinatal mental health is extremely important. Not only the mothers who have diabetes, even you can pick up some mothers who after birth, they feel very low. And we have this Edinburgh scale, which we use, questionnaire, to all the mothers in the wards. And then when we sit and find out a change in the mother whom we have seen in the antenatal clinic and sit and talk to that issue, they open up. And some may not be. So we have this Edinburgh scale, and we take the score more than 9. And then we have a psychologists in our hospital where we give the sessions to them, and this is now has become mandatory to check perinatal mental health for every mother coming into the clinic. We need to give the privacy in the antenatal clinic in every trimester, because most of the mothers, they have some fears which come up during pregnancy. They may be good till the 9th month, suddenly the birth, that fear comes in. So lactation, I find tremendous problems for mothers. And I think the huge area is the lactation part, where the counselors have to be a part of our routine care. Our nurses and our midwives and the lactational support systems have to be so good. So we talk to them, and they are prone for depression because they would have gone through some part of cutting down on the foods which they cannot eat. And if normal birth doesn't happen, they feel diabetes has contributed to C-sections, and not able to breastfeed properly, latching issues. These all will cause depression. And we find 20 to 30% of the mothers, irrespective of the diabetes, they need psychologist help. And few may need a psychiatrist help. So we started slowly networking with the perinatal mental health support systems, and we started a group at one of the hospitals, and slowly we went to bring into the other two hospitals and establish this perinatal mental health department right from the beginning. Definitely, it's an important area where we all have to address.
And do
If
you
I may
also
add, Aparna, yeah,
Sure.
I'm also seeing a lot of postpartum anxiety. So that is again caused by all of these issues, that they're not able to eat what they want, or they're unsure about what they need to eat. There's a lot of difference in advice that are getting about food and exercise and when to feed, how to feed. And that is causing a lot of stress and anxiousness in the mother. And that then again, as a cycle affects lactation in itself. So it becomes a little bit of a vicious cycle for the mother and the baby. And I feel that they're not able to actually, relax or enjoy those initial months. And it becomes very difficult for the mother to move on from that entire period of breastfeeding.
And Dr. Tara, do you also see a role, or how do you, in addition to talking to the mothers, do you also try and bring in, I know culturally fathers are not always involved, but, do you try and bring them in or make them aware about the possibility of postpartum depression? And do you pretty much always see the signs before? That's my other question, if you're...
We encourage the mothers to come with the husband, and right from the antenatal period, we make the husbands involved in the antenatal care and discussion about the birth process, and the husband sits in the labor ward. We allow the husbands to be, in case she needs a surgery, they come into the theater. And once they are involved from the beginning, and sometimes they themselves are able to tell us, like, she's more anxious now. As the date is coming nearby, she's more anxious. So involving the father, the spouses, it really helps us. But sometimes we have this difficult cultural barriers, like, mother has to be there, mother-in-law has to be there. So I tell them, all three come together. Let's sit and talk together. So I go into a doctor's chamber, sit and talk across, because I think they need to vent out whatever they feel. Sometimes the mothers and mother-in-laws feel isolated. They are only taking decisions. They are only involved. What do they know? When do we come into the picture? I said, please come, let's talk. And this is what we are thinking. This is what the birth process is. I feel involving them, then they have a lot of confidence and they help us to understand what the woman is going through, and that becomes easier for us to take care of her, I feel.
Right. Yeah, I guess it is, if not a village, at least a family affair in an Indian context. So,
and may I add one more thing, Aparna? There's a study from Toronto by Dr. Kaveri Dasgupta, who has shown that husbands of women with GDM or partners of women with GDM, they can develop diabetes because of the mother's GDM, because they are, again, like you said, stressed out and very worried about their wives. So it's also probably will help them in the long run if their anxiety is allayed and they're taken care of. So I completely agree that we have to bring all of them in and calm them down. Yeah.
right. Okay, and I guess in that context, hopefully you don't need if you manage proactively, you don't need a psychiatrist. But one other fear, Dr. Tara, is that there's also concern that if I'm prescribed any medications for mental health, antidepressants or whatever, is that safe for the child, especially if I'm breastfeeding? So again, to either, Dr. Shital or Dr. Tara, any advice on that?
It's the same policy which Dr. Usha has said. She can take the medication after the breastfeeding to take the drug. Little percentage will be there, but we have to keep her health, mental health important. So, and we have a dialogue with the psychiatrist too. And we have the group of medicines now very well written, which are safe during lactation, and majority what being prescribed now are safe during the breastfeeding time. So the same thing we tell them after the feed, take the medication, the tablet.
Right, right. Okay. So I will probably go around to each of you now to, again, your final message to, and anything else that you would like to add to the audience today to understand about gestational diabetes and postpartum care or post-delivery care. So I'll start with you, Dr. Tara.
The real challenge I feel is the policymakers and the support services and empowering a woman, because even today, a highly educated girl doesn't tell her diabetes status and gets married and gets into diabetic acidosis in the first trimester. It's really painful to see her suffering. And we have seen one death happening, just came to the ER, and it was a diabetic ketoacidosis. I feel women should be empowered to say that, yes, I have diabetes, I'm getting treated, and I have these problems. As long as we don't empower the women and educate our girls, it's not a sin to have diabetes. We need to face it, as Dr. Usha said. That should be a strong message to our girls, I feel. And to the pregnant mothers, I tell them, it is confidential, yes, but let me say that we do the screening and have found the blood sugars higher. Let's help you out. You can't keep it so to your heart, because you need to take medication. So we try to help them out and help the parents. This is important. You can't hide it. And we will tell them, we will support you, because even today I have a mother where now we had to tell the husband, she had these sugars, we have been treating because he was abroad, and I need to again sit with him tomorrow because she requested me to talk to him tomorrow. This it happens irrespective of education, caste, creed, and religion. So it is an important public health, I think, the message which we all have to help these women, I feel. That's my message.
I think that is really strong and important. I think it really is. I mean, across so many conditions, we find that this whole thing of not being understood or having to hide it is just becoming it's not reducing, and it's really concerning. Dr. Usha, to you.
So I'm actually what Dr. Tara said is like very critically important message, that we should not stigmatize diabetes or gestational diabetes, just another medical condition that needs to be taken care of. That kind of shaming that happens, as if the woman has done something wrong to bring it on herself. Correct. So that should never happen. It's just another condition. So, and I think that can happen only if public education about this is really ramped up very, very well. So important. My message is, any woman who has had gestational diabetes, this is your great chance to actually get onto a healthy trajectory for life, and actually prevent many of the what we call non-communicable diseases like diabetes, heart disease, cancer, and all the drivers of NCDs like high blood pressure, obesity, all of those things. With just one thing, we can actually get a lot of these benefits and actually become a healthier person throughout life. And it's only a matter of eating healthy, being active, and doing those kind of things, sleeping well, mindfulness, yoga, meditation, all of those good things. We don't want people to think it's some sort of, as somebody very nicely put it, diabetes is just a word, not a sentence for life. So no sentence. Yeah.
Right. Thank you. Thank you, Dr. Usha. Dr. Shital?
So I would say that if you have been diagnosed with gestational diabetes, firstly, don't panic. It can be very overwhelming, but remember that it is a temporary and a reversible condition. if you take care of your blood sugar levels. As far as breastfeeding is concerned, breastfeed your baby immediately after delivery and for as long as possible, at least a minimum of 6 months. And this not only reduces the chances of your baby getting diabetes in the future, but it also reduces your risk of getting type 2 diabetes. So again, early detection and proper management is really key. This will have create a better motherhood. A good support system again will help you have a nice breastfeeding phase, enjoy that time with your baby. And as I always say, a happy mother leads to a happy baby.
Right. Thank you. So I think, I think we've had a phenomenal discussion covering a very wide range of topics. And, if I combine this with what we did earlier on managing of gestational diabetes during pregnancy, I think it's quite clear that it is important to understand gestational diabetes. It is important to, as various people have said, not to panic, not to treat it as shameful, but to manage it proactively, and for everyone to be aware and educated. And remember, it's not just, the mother's health that's important, but it affects the baby's health and grandchildren's health. So it is, the future health of of the generation. So I think it is important that we all take this seriously and don't just assume that it will pass and it will be over without being managed proactively. So thank you, everyone. Thank you, Dr. Tara, Dr. Usha, Dr. Shital, for joining today at the end of a long day. And thank you to our audience for listening in. And we will be continuing the series on women's health and gestational diabetes and other forms of women's health. So do write into us if you have any topics that you would want us to talk about or any questions that you want us to address. Thank you very much.
Thank you, Aparna. And it's indeed a privilege to be with Dr. Shital, Dr. Usha, and you. Thank you for the opportunity. Thank you, attendees.
Thank you.